Good afternoon, and welcome to the session, Medicare Expansion and OTC, Expectations and Impact on Hearing Care. My name is Dr. Tom Powers, and I will be with you for the next 20-30 minutes talking about these two topics. So with that, maybe we'll get started here a little bit. In terms of background, I'm currently the managing member of Powers Consulting, a management company providing resources to the hearing health industry. My background is in audiology from State University of New York, Geneseo, and my master's and PhD in audiology from Ohio University. Started off in a private practice in Huntington, West Virginia, and then after several years moved into the hearing aid industry, where I spent the bulk of my career working in a variety of capacities. With that introduction, you could read the rest and spend a whole lot of time there. My disclosures are, obviously, I'm working in my own consulting company. I am a strategic consultant for the Hearing Industries Association and a limited partner in Remote Ear, which is a telehealth company. Today, we're going to talk about Medicare expansion, a little on OTC, and then summarize where I think the impacts are these two will be on the hearing healthcare as it goes forward. So why is the focus on hearing healthcare now? What's causing some of this expanded interest, if you will, in hearing healthcare? I think the changing demographics that we see here with the aging population and the intersection of hearing loss within that group is driving this. The estimates are that in the not too distant future, we will have a group over 65, primarily the boomers, but over 65 be a larger group than those under 18 for one of the first times in our country's history. And the recognition that hearing loss is a public health priority and societal responsibility. We see a tremendous amount of literature in terms of how the comorbidities with hearing loss, diabetes, cardiac health, dementia, and Alzheimer's are playing a role. I think this led to some of the workshops and meetings that were held, starting with NIH meeting, I think in 2009, moving into 15 and 16, 17, with meetings being held by the Institute of Medicine, which became the NASM, National Academy of Science, Engineering, and Medicine. Also the FTC, the FDA, and PSAC, which was the President's Counselors, Advisors on Technology and Science and Technology. All of that drove a tremendous amount of interest and led up to the legislation for OTC devices. We have a lot of changing technologies in the hearing aid business, if you will. Also changes in overall healthcare, but also in hearing healthcare in terms of the products and services and how they're being delivered. And we'll talk more about that when we talk maybe about OTC, but we're seeing a much greater online presence of telehealth being used in the delivery of hearing healthcare. In regards to Medicaid expansion, as we all know, the original Medicare excluded hearing, dental, vision from coverage. Back at that time, potentially, I guess they were viewed more as wellness as opposed to health-related issues. There is some coverage available currently for diagnostic hearing and balance exams and diagnostics, and cochlear implantation for those individuals who meet the criteria. This does not extend to hearing evaluations for the purpose of obtaining a hearing aid or hearing aids or related services. So those are excluded. And only the diagnostic side. Medicare Advantage, on the other hand, does provide access to a hearing benefit. We'll talk more about that in a little bit. Original Medicare, as we all know, has two programs: a fee-for-service health plan that has two parts: the hospital insurance in Part A and medical doctor insurance in Part B. Hearing aids are not covered, as we already mentioned. However, Medicare Advantage does provide a benefit for the vast majority of patients who are currently enrolled in Medicare Advantage programs, which include vision, dental, hearing, chiropractor, health clubs, and other services that are very attractive to members. And that's the purpose of including those, is to have them join that and become a member and expand the Medicare Advantage plan that offers those services. It is Medicare in the private sector. Again, we all know. As of June 2020, about 40% of total Medicare beneficiaries are enrolled in Medicare Advantage. This is a number that's growing and continues to grow. in the Medicare Advantage plans due to the fact that they're offering, again, services and benefits that are attractive. Expected to grow to over 50% of the Medicare population by 2030. The Kaiser Foundation, Family Foundation, found that almost 80% of enrollees in these Advantage programs have some type of vision coverage. 74% have dental and 72% have hearing aid or hearing aid exam coverage. So we see a very high percentage of people who are in these programs. Again, 40 to 50% of total Medicare beneficiaries have these vision, dental, and hearing coverage. The utilization is maybe not what we expect, but the coverage exists, and I think as more people move into these plans, I think we may have thought that these would be where the expansion would take place, but we now know that this is going to take place under traditional Medicare. The reconciliation process, again, we've all been following, so we don't need to spend a lot of time, but this starts off with a budget resolution, goes to the committees within Congress, the committees report back to the main House with changes that they've made within the committee structure to the bill. The total reconciliation bill is considered. Any differences between the House and the Senate are resolved, and then potentially, if all goes well, which we've seen may not be happening right away, the bill is enacted into law or vetoed by the president. So this is a pretty cumbersome, but is the process that is in Congress for doing this reconciliation, and we'll see where this ends up. Right now, some of the priorities that the hearing healthcare community is looking toward, and I think many have been talking to their members of Congress about how this should and they'd like to see work. So these are the priorities from I'll call the hearing health industry, as well as the audiological and professional and consumer groups. That the device should be a prosthetic classification, not durable medical equipment. If it is classified as prosthetic, that exempts the hearing aids and services from the competitive bidding framework, which I think would become very cumbersome in terms of how hearing health is delivered. So right now, that would be a priority, and it appears that that's the way it's going to work. Beneficiary choice is another recommendation from the groups, and that is to have what's called a top-up provision. Would allow the beneficiary to choose a more expensive device and pay the difference if they would like. This exists in some programs. Australia, for example, has a top-up where you can pay the difference between the entry and the middle level or top level device. Access would come down to authorizing all licensed hearing care professionals to provide Medicare covered services. Currently, that's not the case in one of the bills. But again, the recommendation is to have everyone included so that access doesn't become an issue for someone who's maybe in a potentially more rural or not in a city environment where there may be more professionals to provide those services. So in the U.S. House, the text currently of the bill, and again, this recording is being made in early October, so by the time we get to our meeting, things could change, but right now they are classified as prosthetic devices. They are exempt from competitive bidding when furnished to the physician or practitioner's office as a part of their service. And so that's an important part, is that they need to go through the professional, not through some external entity. Hearing aids would be covered once every 5 years, so the patient could get new devices. Severe to profound hearing loss only at this time, and OTC is excluded. Obviously, we don't really have OTC devices in terms of the guidelines. We expect them soon, but right now it is only for severe to profound hearing loss. As it exists in the House bill, audiologists and certain practitioners, primarily physicians, would be able to receive payments, and that bill does not include hearing aid specialists as a provider of these services. As mentioned, that is a recommendation from the groups within the hearing health community. Senate, as of today, or 2 days ago, it doesn't have any specific language. There is support, primarily led by Senator Sanders, for speedier access to benefits. Here you see the phase-in. That's a proposal right now for vision to be phased in 2022, hearing in 2023, and dental not till 2028. They would like to see potentially speedier access by providing potentially debit cards while this is being implemented. Manchin and Sinema, obviously two senators that are critical, and we've been hearing a lot from them recently, remain pivotal in whether or not this might take place and actually pass and get done. So this is pretty comparative to previous legislation. That was HR 3 from the previous Congress, again, classifying hearing aids as prosthetics. While the current bill only includes audiologists, HIA, audiology associations, are trying to work to get licensed hearing aid professionals, anybody within the scope of practice today, into the Senate language. Audiology is certainly working on the Medicare Access and Services Act, or MASA, to reclassify audiologists as practitioners and eliminate the need for a physician order for coverage. These are all things to streamline the access part, and obviously the coverage is to deal with some of the affordability issues that may be put up in terms of getting hearing aids today. The CBO, or the Congressional Budget Office, scores costs for all things that Congress is considering to spend money on. It fixed a 10-year program for the previous bill, which was HR 4618, at approximately $30 billion over a 10-year period for vision, about $89 billion for hearing, and $238 billion for dental care, which I think leads us to why the implementation phase-in periods were established to phase in potentially the lesser cost options for vision and hearing before dental. But again, that remains to be seen if that's going to happen. I think one thing we should note that even if this does happen, the implementation could take some time. When the Part D Medicare was implemented in terms of prescription, from implementation to when it actually became effective was about a 3 to 4 year period to get that moving and implemented. So this may take some time as well. So that's where we are on the Medicare expansion, and we may have more to discuss in the question and answer period next month when we get together for the meeting. In terms of over-the-counter hearing aids, we now know that the rule was included in the spring agenda from the FDA, and that OMB has issued at least some recommendations to the White House, and we believe that that has now moved back to the FDA, and we could expect very shortly, maybe still in October here as we're recording this, to see those draft regulations. President Biden did issue his executive order asking them to speed up the process and to get this done in the next 120 days from when his executive order was issued. So we would expect that sometime here in October or November, there would be a publishing of those rules in the Federal Register. There is a 60-day comment period for all stakeholders and everybody to comment. The FDA then has 180 days to respond to those comments and or change anything in those rules. At that point, they would issue the final rules together with, obviously, their comments back to those people who submitted comments. And generally, 30 days after that is published in the Federal Register, those rules go into effect. So as you can see from the timeline that's anticipated there, that expects us to have the full release and devices under the OTC labeling available sometime next summer. We'll see if that holds true, but we think that's a reasonable timeline at this point. Because this has been delayed, obviously well over 3 years and close to 4 now, this new channel, the DTC or direct-to-consumer channel, has evolved. The FDA has said that it is different than OTC. We do have the first direct-to-consumer device that's been approved, which is the Bose device, which was approved as a self-fit direct-to-consumer hearing device. However, we do have a couple of other systems for delivering hearing healthcare that have evolved. And these involve either having a professional involved at some level or none. A number of companies are involved here, and I'm not going to go into each of their offerings, but we have some that you buy the device online, and there's either an app potentially or instructions on how to use it, how to get in your ear, etc. Some do have a professional involved, and that could be either a customer service, person, somebody who's trained, could be a hearing professional, whether an audiologist or a dispenser, who provides help via either a chat or an online chat or phone call. And then some do have professionals involved, Lively being the probably best example many of you may know, where hearing test is done online, the device is pre-programmed, the device is sent to the user, the consumer, and then a session is set up for that professional to help that person with the fitting. And typically those professionals are licensed in the state where the consumer is actually located. So while the professional may be somewhere else, they are under the Lively model licensed in that state to provide those telehealth services. And others have similar models as you see there with a number of different companies. So DTC, my expectation is, will morph into the OTC regulations, and all of those devices will need to be either registered, 510K, whatever these guidelines turn out to be when we see them in the next few weeks. I think another agency that we need to take a look at here will be the FTC. The Federal Trade Commission has jurisdiction on false and deceptive advertising. In terms of how this works within the two agencies, they have a memo of understanding that FDA is primarily involved in the labeling, safety and efficacy, and the FTC primarily has jurisdiction over the advertising. And they have issued some letters and warnings and fines to people that have made unsubstantiated claims about their devices. And again, even if it's true, it's deceptive if you don't have substantiation for the claim. So the FTC has pretty broad reach. They were also the agency that issued what's now been referred to as the eyeglass and contact lens ruling a number of years ago in vision, where you receive a copy of your vision test results prior to any discussions about whether you will purchase your vision services and products at the place where you got the testing. Then you could use those test results to put her online, either for eyeglasses and or through the various sites that offer contact lenses. So unbundling, I think, is another issue that we're going to have to begin to think about how this will work in practices that are providing hearing healthcare. And one or more of the things are probably going to happen, and that is the FTC, as we just mentioned, could, once the FDA guidelines are out and we move forward, could issue guidelines very similar to what they did in vision, that you go and get a hearing test, and once you have the results, then you can make a decision about where you purchase services and products. OTC pricing will, I think, have an impact, and that is those devices are going to be sold as device only with no professional services. So you see the unbundling taking place there. Some of the online models do include services, but I think as patients begin to see the cost of the OTC devices, we already have somewhat of a benchmark with the Bose device at $849 for two devices. So if that holds true, we expect the devices to be in the $300 to $400 or $500 range per device. Consumer demand, when they come into the office, they may expect that the device, whether that's OTC or traditional hearing aid, is separated from the professional services. And again, Medicare expansion, because it is a fee-for-service model, is not an unbundled. It's an unbundled, if you will, model, and not a bundled model. So that may also have an impact on how this plays out. Although it will start for severe to profound losses, it may have an impact across the entire pricing structure for hearing aids within hearing health. So I say there will be probably still a single fee model in the private market for those that are outside any insurance, whether that's Medicare, private insurance, or anywhere else. The OTC products are a little bit different, but also an unbundled fee for service and products for patients who may have either an OTC or a traditional device. The product pricing would be separate, and then services, whether that's short-term or long-term, may be separated out the way they were when I first was in private practice back way in the late 70s and early 80s, when everything was unbundled due to the ASHA ethical considerations, where audiologists were not allowed to profit from the sale of hearing aids. And so every service was itemized: the hearing test, hearing aid evaluation, ear mold impression fees, etc. And so follow-up services, whether you're a new or existing patient, could be very different. If it's your second or third set of devices, you probably know a fair amount about how to use the device, get it in your ear, where to go and sit when you are in a meeting with background noise. New users may need a bit more attention, and so they may need more follow-up services. And how those are priced and structured, I think, is something we need to be thinking about, so we're ready that as this potential new pricing structure comes into play, we see how it will work for each and individual practice, because they're all going to be very different. What is the impact of all of these, if you will, on dispensing offices? I think consumers will expect coverage regardless of hearing loss. They may hear the Medicare expansion happens, they'll hear about OTC, the advertising is going to start, and they may decide that they like a professional opinion on what's going to happen and think that they have coverage. So we'll need to have materials or dialogue ready to explain what their hearing loss is if they have a hearing test, or that they should certainly get a hearing test first to decide where their hearing loss lies, but to make sure we explain how that works. Many consumers may expect that OTC devices will be dispensed through your practice. I've been referring to these as OTC devices because I don't know what they're going to be called, but if they're referred to as OTC hearing aids, then in the consumer's mind, a hearing aid is a hearing aid. And so they may not be able to differentiate those and think that they only can buy them online, that they will be available through your practice. And I know that's a discussion that each practice is going to have within the practice. Are we going to select a few OTC devices and have them available for patients who may want them? And then how will those be dispensed? What services come along with them, and how will they be priced? Or they may make the decision that that's not something that's going to happen. And I think that's a debate that has to happen within each practice. However, once the decision is made, if you do have OTC devices, how you triage those patients through the practice, and how much time is spent with them, how much billing goes to that particular practice, and that patient, I should say, is going to be important. The structure and how much time is set aside for an OTC versus a traditional hearing aid patient could be significant, from a half an hour to an hour and a half appointment. And the scheduling structure within the practice is going to have to leave time slots for each of those types of patient. I think the other issue is, how do we decide when someone comes in and starts asking questions, what are they a candidate for, and how are we going to assess that? Certainly the hearing loss is one of the first things, and we would encourage everybody to get a hearing test first to find out whether or not you have a mild hearing loss, moderate hearing loss. As we know, self-perceived hearing loss is usually milder than the actual hearing loss. Many people believe their hearing loss is not nearly as bad as it might be from having a hearing test. But we also need to find out how well they're doing in the environments where they feel they are having difficulty. Many early users, mild to moderate hearing loss, are situational wearers. They wear them potentially only when they are in background noise, in a meeting, in a restaurant, when family gatherings, etc., because they feel and probably might do okay in quiet environments. So how do we do that in a practice? Do we use the hearing test combined with hearing and noise tests, some questionnaires, hearing health, handicap inventory, etc.? How are those patients evaluated, and how are they counseled in regards to what type of device would best suit their needs? I think we have always looked at entry level, medium level, and high level devices. I think we may need a fourth category, and that is the OTC devices at the lower end for the mild to moderate, and or those people that are even on the cusp of normal hearing. I mean, we have a number of individuals who have fairly normal hearing with what we refer to now as hidden hearing loss that are having tremendous difficulties in background noise. Are those people considered to have normal hearing, or are they considered to have mild hearing loss, even though audiometrically they're under 25 dB? They have significant issues in background noise. And those patients may be some of the patients where an OTC device could provide them some help, and especially in situations where they find themselves having difficulty understanding. I think also the last point here is consumers will seek transparency, pricing of products and services. We talked about this a bit earlier. As more and more advertising is going to take place, more marketing is going to take place for the OTC devices, which will be separated for the most part from the service component and the product. That overall transparency of what devices cost will be something consumers are going to know, and they may ask, how do you separate those products? What am I paying for? Medicare expansion is going to have the impact on that, and those patients that are in the severe to profound category, being more a fee for service model. We don't know yet how that's going to be structured, but potentially each service would be separated. So the hearing test would be, the hearing evaluation, the fitting would be a separate billing code. Follow-up services would have special and separate billing codes, as well as oral rehab and other treatments post-fitting. So how this works, we still don't know, but I think it's something we need to be thinking about in terms of how both OTC and Medicare are going to impact all of these things. Consumers are going to be coming asking questions for us, and I think we all need to be prepared on how to explain how our practice works, what services we have, what products we offer, so that we can do the best that we can for each and every consumer and every patient who walks into our office. So with that, I'm going to say thank you for your attention. Thank you for being here, and I think we'll be moving to a question and answer. So again, thanks again, and have a good rest of the day.
Hi, I'm Matt Gracie with Dan & Gracie Risk Strategies. I am so pleased to be talking to you today at the FCOM meeting, virtually and physically. But of course, this is the virtual version. So my agenda today is to talk about how important the unity of defense is in a malpractice case and why you need to prepare for those unity of defense issues and how to do so. I also want to cover just one of my favorite subjects, and that is the abundance of risk management resources that are available to you on the MedPro website for being a member of the NFO Risk Purchasing Group. We have been involved with the NFO for many, many years, really from its inception, and are very pleased to report that the insurance purchasing program, which is part of the NFO, has been highly successful. If you have any questions about it, of course, reach out. So let's jump right into the slides and off we go. So the importance of a unity of defense. The number one goal, as you can see, is just don't let this happen. This is really the only screen I would need for the entire presentation. This is what plaintiff attorneys love. It's one of their main strategies in a multi-defendant case. Almost every case against doctors these days is a multi-defendant case. And how do they win? Well, they get everybody pointing their fingers at everybody else. And you would think that would be an easy thing to stop, but in fact, it's not, because as you can imagine, there are a lot of personalities involved, but it goes even deeper than that. It really goes to the structure of the insurance representation too. Each insurance company has their own claims representatives, and of course, they assign an attorney to defend a doctor and the practice when they're sued. Each one of those claims adjusters and attorneys and doctors have different strategies. And so what does a plaintiff want to do? They want to get all those strategies just conflicting with the others so that they can come in and convince a jury that the doctor and the practices are at fault. And that's how big awards and settlements are created. So the whole thing is not to let that happen. But again, not as easy as you would imagine because of the insurance representation. With a whole bunch of different insurers involved, there will be this blame game going on, and that will result in settlements that are just unpredictable, but also unnecessary at times to the plaintiffs. One of the things that people are very confused about is other insurance clause in insurance policies. If we were doing this in person, I could ask the audience, well, how many of you have studied your other insurance clause in your malpractice insurance policy? I can guarantee you, well, maybe one hand would go up, probably some person who's been through a major lawsuit and had these explained to them. But most people have no idea how this all works. And that's, again, one of the problems. People are very well intentioned, of course, when they buy insurance policies. They think, well, I'll buy an insurance policy and sleep better at night. That sounds like the right goal as well. But when there are multiple defendants with multiple policies involved, things can get very complicated. And that's really what this presentation is about, is to simplify all that so that the defendants in a case, at least the defendants that you can control, are And that's the point, is that in cases that have multi-defendants and defendants that you have some control over, you want at least to have the same insurance policies. Oh, Lord, I'm recording. Jesus. All right, let's start again, Steve. So that's really the point, is that in multi-defendant cases where there are a bunch of defendants, but also a bunch of insurance policies and reps and lawyers, as I said, it all has to be coordinated. And guess what? Sometimes it doesn't coordinate very well. And sometimes that's, again, the fundamental mistake that purchasers make. When you buy an insurance policy, you think it should cover you, right? Well, it does, but this other insurance clause might say, if you have other coverage, well, they're going to be primary, or this policy is going to be primary. Again, it's very convoluted. So the trick is to have good coordination, but in my opinion, that's nearly impossible when it comes to big multi-defendant cases. And again, that's what plaintiff attorneys count on. So here's some examples of folks that you might not be able to control as far as what insurance policy, what insurance carrier they have defending them. Of course, hospital-based doctors who might be a co-defendant, it's impossible to control their insurance coverage. What about all the employees of a surgery center that might not be one that your practice owns? What about all the referring physicians as co-defendants? There are so many possibilities of doctors being your co-defendant where they're going to have different insurance, that the point is you really want the ones where you can control within your own practice to have the same coverage. A great example of this is with all the APPs and audiologists in otolaryngology practices. Of course, many audiologists have gone out and bought separate policies from a number of different companies offering them, and they're not expensive. And so they're very attractive to audiologists, just to go out and buy say $1.3 million limit, which is a standard policy you can purchase on the market for under $100 usually. But again, what happens is now you have just brought another insurance company, another insurance rep, another attorney into a case, versus if that audiologist had gone with the same company that insures all of the doctors and the practice. It would be a coordinated defense versus a bit of chaos. And the last thing you want in a big multi-defendant case is chaos. So there's one other group that you can't rely on either as a co-defendant, and that is the uninsured. What's happening in Florida is we're one of the only states in the union that allows a doctor to practice bare. That means without having insurance. So bare doctors, their strategy is, well, if I get sued, I'll just tell the plaintiff that, well, I don't have any insurance and I've protected all my assets, so pound sand, just go away. And well, that is where it gets complicated. What we're seeing on a regular basis now are the uninsured doctors being very much compromised by the plaintiff bar. The plaintiff bar basically says, gee, doc, if you want to get out of this case, then you're going to have to really point your finger at some of your co-defendants. We're not going to just let you out because you have no insurance. We will pursue you those assets, and we'll work very hard to try to get you out of practice if you don't point your finger at your co-defendants. And it seems to be working. And that's, again, one of the problems of having folks around who are uninsured, either uninsured or, again, with different insurance policies with different companies. So I think I've beaten that point. So for the second half of the presentation, I just want to really talk about the risk management resources that are available to all of the NFO insureds. And if you're not an NFO insured through MedPro, then your own insurance company may well have some resources. We find that MedPro's risk management resources are absolutely second to none. They know otolaryngology. They insure a lot of otolaryngologists, not just in Florida, but around the country. And their risk managers, you've probably been on some webinars with a number of them that the NFO so greatly does monthly. And they share some great knowledge. And I'm always amazed how few people know what deep resources are available, again, free. So the risk managers themselves, you can call a risk manager when you're in doubt about anything. You can call me, you can call the risk managers. Risk managers are the real pros. When we get difficult questions, we always involve a risk manager, and I can tell you, you will be very satisfied with some of the advice you will get. Look at some of the resources here just on COVID. I know we're all sick of the COVID discussions and articles, but again, some very important information. They have great continuing ed as well. The doctors can go on and get discounts on their policies by doing the continuing ed through the MedPro website. And there are a bunch of very timely subjects, as you can see here, from cybersecurity down to just basic strategies of disruptive behavior, and on and on and on. Just way too many for me to even begin to highlight. You can see here, again, just a real sampling of some of their resources. And they have some new ones. Many of you might have gone on to their website a couple of years ago. Well, go on again, because they're constantly updating and improving this site. And again, all free. And if you have any issues of accessing it, just go to our danandgracie.com site, go on to the NFO page, and we'd be happy, or you'll be easily directed to these resources. Thank you very much. We're very honored to present at the FCOM meeting, and wish you all well.
Welcome to this educational session on the impact of documentation. I'm Teresa Phillips, a patient safety and risk consultant with MedPro Group. I appreciate the opportunity to speak with you today, and I hope you are enjoying your conference. I have no disclosures or conflicts of interest with the presented material in this presentation. My bio information is included in the slide deck if you're interested in reading additional information about my background and training. Accurate and thorough documentation is the backbone of risk management. It provides essential patient information, historical details about the course of patient care, and a record of services provided. And there's many functions and benefits of quality documentation. First and foremost, documentation facilitates safe patient care. A patient's medical record is an important tool and resource for the patient's care. MedPro continues to see the impact of documentation on patient outcomes. Our claims data reveals that 25% of all significant patient injuries involve a documentation issue that negatively impacted patients in some way. Documentation is also one of the best ways that we communicate with the entire healthcare team. Having a well-constructed patient record provides the entire team with a complete, accurate, and timely account of the patient's current status and needs. Memories certainly fade, which is why documentation of the care provided to patients is very critical. Documentation serves as an evidence of the care that you give, when it was given, and whether it was given in accordance with the recognized standard of care at that point in time. It reflects the professional care that you provide. It's often said that when you and your patients or their family members have differing opinions or versions of the events, the medical record is referred to as the unbiased witness because it was created prior to any patient outcome or litigation. What is or is not documented can really impact your credibility, which is a crucial component of your defense. A well-documented record certainly provides the best defense in a claim. Claims data continues to reflect documentation issues, as I mentioned. MedPro claims data tells us that the majority of documentation issues occur in the outpatient setting. You can see that at 61%. Within each setting, we see further breakdown of the areas in which documentation issues occur. For example, in the inpatient setting, 39% occurred in the patient's room, including the ICU. In the outpatient, 56% occurred in the physician's office or clinic. We really get busy in the course of a fast-paced workday, but we need to make sure that we're documenting because we can see the difference and the impact that it can have on patients. Here's the main documentation issues we find in our claims data that impact safe, effective patient care and your credibility. The most frequent issue we see is insufficient or lack of documentation in 70% of the cases, and this includes not recording important aspects of care, such as clinical findings, interventions, treatments, reassessments. Inadequate documentation can result in incorrect treatment decisions, unnecessary procedures or medications, and care that's not provided when it's indicated. Inadequate documentation that reflects the thought process, such as our clinical judgment or critical thinking regarding the prevention, diagnosis, or treatment of a clinical problem, is also a contributing factor in patient outcomes and the defense of claims. For example, our failure to document and communicate critical test results can lead to suboptimal patient outcomes. Other scenarios that highlight the impact of insufficient or incorrect documentation in a surgery center, for example, would be that delay in dictating the op note followed by an emergent need to return the patient to surgery or something like that. Also, inconsistencies in documentation between members of the healthcare team that are not reconciled are problematic, and they represent 23% of the cases. Such inconsistencies impact patient outcomes. For example, think about wrong site surgeries, inconsistent documentation of the intended procedure site, education, patient understanding of information that is shared. So these types of issues certainly present a problem. The mechanics of documenting represent 17% of the cases, and they include illegibility in paper charts, incorrect or inaccurately transcribed orders, for example. If we think back to our claims breakdown in the previous slide, we note that the top issue in documentation claims is lack of or insufficient evidence of critical thinking. The missing elements that support our critical thinking and clinical decision making includes assessments and reassessments. And a frequent example of that is no documented reassessment after maybe a medication's been given, or sometimes it's a situation of a patient's in and out of the office, but you can't tell by looking at the record, what was the provider thinking? What was the provider considering during the course of that diagnostic procedures? For safe patient care and credibility in the defense of a claim, documentation should really connect the dots. Our observations, actions to those observations, and the result. Plaintiffs and jurors measure care provided by what was or was not documented. So we need to make sure our documentation reflects our critical thinking, practicing within the standard of our professions. An analysis of 10 years of MedPro closed data shows that documentation issues consistently are in the top 5 risk factors associated with inpatient claims that have clinically severe outcomes. Across inpatient and outpatient allegations, documentation missteps are most frequently noted in diagnostic, surgical, and medical treatment allegations. And these categories are fairly balanced, as you can see, 23%, 23%, and then 21% for medical treatment. When we look at inpatient claims only, surgical allegations quickly rise to the top at 75% of the claims for inpatient involve documentation related to a surgical encounter. Some of the basic documentation do's and don'ts, but they certainly need to be reminders to us. Don't take shortcuts in electronic record systems, including copying and pasting medical records. It can lead to carryover of inaccurate or outdated information. It certainly takes more time, but it's important to type out your notes every time. Do make sure you're charting on the correct record. With so many patients in and out of your offices, sometimes it's easy to sit down and start documenting on the screen in front of you in the incorrect chart. Don't delay documentation. It's too easy to forget the details if there is a delay between the time that you took an action, saw a patient, and if you delay in documenting. It can just lead to a host of problems. Don't document things that haven't been done yet, such as medications or treatments. Again, that can become an issue, and we also want to make sure that we're not fraudulently charting. Do use the patient's own words, gestures, and nonverbal cues as much as possible because it really helps to paint that picture of what you encountered. So avoid using those vague terms. Make sure that you're following policies, your organizational policies when it comes to making corrections in the record and late entries, and those should be kept at a minimal. Also, when we think about texting language, that's something that I've been noting when I've been doing recent chart review. Texting language is open to interpretation. And so there's certainly a lot of times generational issues or variations, if you will, in texting language. So make sure that we don't use texting language in documentation. Inconsistent documentation can be an issue as well, and they can occur between point and click boxes and narratives. Historical data sometimes in problem lists and medication lists. So we need to be cautious about that. So for example, on the intake note, the medical assistant may enter no shortness of breath. However, in other portions of the record, chief complaint may say that there's shortness of breath. Inconsistencies in our own documentation or between members of the healthcare team that are not reconciled are problematic. So some of the areas I typically see that is in that chief complaint or the reason of the visit, and then something different is noted when the provider sees the patient. So make sure that documentation content is correct. Take the time to review what other members have entered into the chart so you can reconcile any of those corrections that are necessary. Just as important as the documentation itself, sometimes the electronic health record system can have some issues that are worth noting. Automatic timestamps that don't appropriately reflect exactly when tasks occurred or when procedures are done sometimes can impact the ability to clearly recreate a timeline of care. A very common is review of allergies. I've just seen numerous records in which it appears that allergies have not been reviewed for an extended amount of time. And what really happens is that allergy status was reviewed with the patient, but the box was not checked. And so it does not indicate that it was reviewed. Also, alerts and overrides, be careful of those. Pre-charting. That's an issue from time to time where people go in and pre-chart and then the patient no-shows or there's an issue. So be cautious with that. Sometimes it's incompatible systems and routing of information, such as lab reports, radiology reports that are coming into the system. Maybe they're not routed appropriately. And so it can lead to a failure to diagnose or delay because you do not see that information. Free text fields sometimes have a preset limited space for adding comments, so things can kind of get cut off. So be aware of that. Also, lack of or failure of alerts and alarms to provide that safety net. I've seen in numerous offices that turn those off, and that is your safety net. That's your alert for positive tests coming in and flagging things that need to be reviewed. So be cautious of that. Sometimes it can be missing information or some fields that are left open, incomplete. So be mindful of any of those open fields. And then also sometimes updates, information may be lost, no longer available when updates occur. So a lot of different things with the electronic health systems. So a couple of case examples I'd like to share. One is this 40-year-old patient that had been treated in this medical office for a good period of time. He had been treated in the past for pharyngitis and had received antibiotics. Several months later, the patient calls, and it was early in the morning, and so he got the answering service. He had a complaint of malaise and cough for 3 days. Later on, the office called and spoke with his spouse, and the member of the office stated that they would speak with the provider and give him a call back, but they had indeed received the message that he had called in. A medical assistant called the patient and stated that the provider could not speak with the patient as the office was too busy and they did not have an appointment available, but the provider could call in a prescription for antibiotics as it sounded very similar to a previous illness. Staff members did call in that prescription. However, the patient expired within 24 hours, as you can see from a cardiac arrhythmia. Problematic area in this case was the scope of the person that managed the calling in that medicine was outside the scope of their duties. Also, the office policy, there was a written policy that stated prescriptions were only provided after a clinician spoke directly to the patient. That policy was not followed. Also, typically, if a patient is unable to be seen for whatever reason, most offices always recommend they go to the ED or the emergency department or see another provider, such as urgent care, that type of thing. That was not captured in the record, so we're unclear if they did recommend that. So documentation in this particular case was an issue, and you can see, as demonstrated, several areas there. Also, another is a case example with an undiagnosed brain tumor, a 46-year-old female patient that had a 3-year history of episodic vertigo, was diagnosed with positional vertigo. She had been worked up for a period of time, over a period of months. After numerous visits, the patient had physical therapy for different things, also was referred for an ophthalmology consult, referred to a dentist for possible TMJ, and then also referred to neuro. This patient was back and forth in the office, and there was some challenges with timely referrals and that type of thing. The patient ended up being referred to neuro as one of the final consults or referrals. The patient canceled that and made her own referral. And as you can tell, she did have a brain tumor that was identified on some studies that were completed. There were a lot of problematic areas with the case. A lot of the issues were maybe the assessments were done and that type of thing, but there was just limited documentation. So unable to paint a clear picture of what went on with the patient. Again, thinking and documenting is two different things. So we need to capture that. So there were very limited documentation related to the communication among the providers, related to those consults that have been made, limited documentation with follow-up phone calls with the patient and communicate with the patient about their signs and symptoms and continued issues. So again, documentation played a critical factor. Documentation can be defended when it completely tells the patient's story. So the story should not have any gaps in it. And it must make sense to the person that's reading it. If the reader is another member of the healthcare team, attorney, or the patient themselves, it needs to make sure, and it needs to create that timeline of care. and then also needs to comply with organizational policies and procedures. When we consider all the things that need to be documented, there's a lot of information and it can be very overwhelming. So we need to just make sure that we are focused on those key things. The key things: assessments, interventions, and patient's response to interventions. You know, if we're working up a patient over time, making sure we capture what we're doing with that patient. Acknowledgement of tests, those test results, those referrals, closing the loop and making sure documentation reflects that closing of the loop. Discussing with the patient as well. If there's changes in patient's condition, we're capturing that. We're communicating with other providers, other people involved in the care and treatment of the patient. We're doing some teaching to the patient, educating the patient, making sure the patient has a clear understanding, and all of that information needs to be captured in the record. Significant conversations need to be captured, as well as unexpected events and incidences. We need to capture those in the record. A lot of things we need to capture, a lot of concern when it comes to documentation. And as you can see, we have continued issues with that. So next steps, what can you do following this presentation today? Takeaway steps: look at quality improvement. You know, you need to audit some charts. You need to know what's going on within your practice. And again, having a plan to address those. As we all know, not all outcomes are within your control. However, documentation is in your control. A good chart defends itself and those who wrote it. So I would encourage you to do some audits, do some check-in. And I've got some resources added into the presentation here that you could use as takeaways to identify also some checklists for documentation essentials, electronic documentation, as well as a good risk management review on some documentation errors and what you can do to make some changes in your practice in providing excellent care to your patients and also capturing what you do as part of your everyday work. Again, it's been my pleasure to do this presentation for you today. I provided you with my email contact information. If you have questions and follow-up of this presentation, please don't hesitate to reach out. And again, I hope you have a wonderful rest of your conference.
Hello and welcome. This is Joe Sakamura, Director of Centers of Specialty Care at the American Institute of Balance. On behalf of Dr. Richard Gans, myself, and the entire AIB family, we'd like to thank you and welcome you to our talk. Managing the dizzy patient in a busy ENT practice is the topic of discussion today, and we've got a lot of wonderful information to share with you. We're going to be dispelling some myths about vestibular, about the dizzy patient, and ultimately walk you through how we can do well by doing good. How to take care of these patients, produce excellent outcomes, and also generate significant revenue streams, all within the four walls of an ENT practice with minimal space and very, very approachable equipment purchase price as well. So we're going to be talking through what this might look like. We're thrilled to have you here, and we'll go ahead and get going with our presentation. The first thing that we've got to discuss when looking at what dizziness and balance conditions look like throughout the lifespan is how this is truly a birth-to-earth set of conditions. This is not just the older adult that has an attack of vestibular neuritis. This is not just Meniere's disease, and this is not only otologic conditions. So when we talk about these, we really like to approach these actually starting at birth. Babies can have problems with the vestibular system. There are over 500 syndromal, non-syndromal, and mitochondrial disorders that actually have vestibular expressivity. So we know that with congenital diseases and disorders, typically the problem is bilateral, and it may not be caught until the child starts to miss motor milestones, isn't walking at the appropriate age, might not be rolling over in their crib, can't ride a bike. So very, very often these children are missed and misdiagnosed as having some type of a developmental delay, right? And the vestibular system is almost overlooked. So we've got to understand all of these mitochondrial, syndromal, and non-syndromal conditions. We've also got to look at what test battery we have for young children. In the picture here, you see a cervical vemp being performed on a 3-month-old. You actually can get great responses on children of this age. Information on the saccule, information on the inferior branch of the vestibular nerve. So a lot of really wonderful information that can be gathered by children as young as 3 months of age. We also can see in infants BPV of infancy, the earliest form of migraine. So you don't have obviously the classic baby that's going to tell you I've got vertigo or I've got dizziness, but they absolutely can be influenced by vestibular diseases and disorders. When we look into young adults, 8 to 30 years old, very, very hot topic in the world right now, sport concussion. We know that the most commonly concussed individual is not an NFL athlete. It's a female adolescent soccer player. So we know that you can have cortical concussion. You can have diffuse axonal injury, blood flow issues, metabolic damage to the brain. But you can also have labyrinthine concussion, damage to the inner ear that results from a head trauma. So understanding the difference between those two, understanding what is contributory to the patient's symptoms is critically important when making return to play or rehab intervention decisions. So again, huge population for us to take a look into is the concussed individual. The most common symptoms after a concussion are going to be headache and dizziness. So a big deal when looking at the young adult. When we look at the next column over, 12 to 50-year-olds, we have migraine is a huge deal. Could be puberty onset, could be dizziness, could be headache, right? 1 in 4 females, 1 in 6 males. Migraine is the most common cause of non-otologic vertigo. So patients with migraine are very, very important to address here. Why? Not only because migraines themselves can cause dizziness and vertigo as well as balance problems, but also otologic conditions are 3 times, like BPPV, for example, is one example. BPPV is 3 times more prevalent in patients with a history of migraine. A great deal of migraineurs also will report vertigo as an aura. So we now have, the Barony Society now has diagnostic criteria for vestibular migraine. So you can have migraine with or without an inner ear vestibulopathy. Understanding, doing the diagnostics and understanding the function of the vestibular system is the first step in figuring out where the problem is ultimately coming from. So migraine, of course, much more prevalent than ear disease like Meniere's, for example. Migraine is also very hormonally regulated. So estrogen, progesterone, pre, peri, postmenopausal females, really, really important to take a look at migraine when you look at patients that are 12 to 50. In 50 plus, we really start to see otologic disease and disorder, vestibulopathy, become an issue. BPPV, the #1 cause of vertigo for individuals 50 and up, often as easy as 1 to 2 office visits will fix this, right? We know that BPPV elevates fall risk. We know that BPPV elevates anxiety, depression. So we've got to get these patients in and managed in a cost-effective and efficient way. Shingles, we start to see the most common cause of otologic vertigo at this age. The herpes simplex virus. It's opportunistic. It lives in the spiral ganglion. And when the patient has, for example, a period of reduced immune function, right? Their immune system is suppressed or worn down, the virus loves to reach out and attack the balance nerve. Very, very common cause of vertigo. The second most common cause of otologic vertigo. So we also see in the 50 plus range, postmenopausal migraine again becomes an issue. Could be dizziness, could be ataxic gait, stroke-like symptoms. They could have a number of other different issues going on, but migraine is a big deal in these patients. So 65 and up, the old adult, also very, very important to evaluate these patients, right? By age 70, 50% of all individuals will have had BPPV at least once. What do we also know about the older adult? Fall risk management, multifactorial equilibrium problems. They've got hip problems. They've got back pain. They've got ankle issues. They've got knee replacements. So understanding where the problem is coming from, understanding how intact the modality of vestibular is, right? Because equilibrium is a composite of eyes, ears, touch, and brain. So understanding, even if we know that someone who's maybe cane or walker dependent, even if we know that they have biomechanical issues or structural problems that are contributing to the balance problem, is the ear helping or hurting us? And what type of rehabilitation or non-medical management is going to yield the best outcome for these patients? So dizziness, of course, the #1 complaint of all individuals over the age of 70, right? #1 complaint of older adults. Dizziness is the #3 complaint of all individuals across the lifespan, preceded only by lower back pain and headache. 10,000 adults turn 65 every day. So these patients absolutely need to be taken care of. And ENT practices are probably the best suited folks to manage these patients, so long as you have in place the diagnostics and the non-medical management approaches that need to happen. So MTBI with falls, of course, aging in place is a big deal to these individuals. It's also a big deal to the medical economic system. So this program, right, the idea here is to reduce cost containment, to reduce the quality of life cost, and also reduce the medical economic cost. We want to get these patients better as quickly and as affordably as possible. Everyone wins in that scenario. We've already kind of addressed the why somewhat on the last slide, but why is this so important? Dizziness, the #1 complaint of individuals 65 and up. There are 90 million Americans that fall in this category. Huge shortage of specialists that are equipped to treat and to manage this population. We've got to be the ones that establish a continuum of care that's ultimately going to yield improved outcomes. According to the NIH, the average dizzy patient will see 4.5 doctors before receiving a diagnosis of even something as simple as BPPV. Right? The most recent estimates are that BPPV diagnosis is costing in total the medical economic system about $2,600 per patient. It's a really, really big deal. Effective management of these patients is often very complicated. So what we want to do is avoid this idea or this concept of, oh, you're getting a little bit older. This might just be part of the aging process. Or, oh, maybe meclizine will help your problem. Let's try that and see if that works. Rather, we want to do full comprehensive diagnostics, which are going to guide the non-medical treatment plan. Because the vast majority of patients with dizziness, vertigo, and balance problems are not surgical and not pharmacological candidates. So ultimately, they'll end up likely in vestibular rehab or some type of non-medical treatment plan. The diagnostics are going to help guide that plan and help improve the outcomes that the therapist or other individual is going to be able to produce. In the management of these patients, the role and the value of the neurodiagnostic vestibular evaluation cannot be overstated. Remember, we've come a very long way since this testing just involved the VNG. So rather than using the word vestibular test, we're going to use strategically the term neurodiagnostic vestibular evaluation, because we're able to evaluate all 5 end organs of the periphery of the vestibular system, as well as both branches of the vestibular nerve and their neural substrates of integration. So evaluation with this neurodiagnostic battery, the AIB protocol, what we teach and our centers perform, the evaluation not only will help the physician make an accurate medical diagnosis and triage, but also this is going to identify specific non-medical management strategies when warranted. So this is going to improve the rehab provider's ability to take care of these patients by having the whole picture. So again, not only the big value of this test battery is not to aid the physician in making a medical diagnosis necessarily. The greatest value is that the physical therapist or the non-medical management strategy is going to where our outcomes are ultimately going to be improved. So this is often the first and most important step that needs to be taken. The good news is all of these tests can be completed in about 100 square feet of space. So not only is it going to help the medical diagnosis, but also the non-medical management approach. So for a long time, we've understood the candidacy for otologic patients and why you would want this testing. Classic cases like BPPV, vestibular neuritis, labyrinthitis, Meniere's disease, potential retrocochlear involvement, right? Syndromal, non-syndromal, children with delayed motor milestones, cochlear implants, sudden onset sensory neural hearing loss. But let's not forget about all of the non-otologic patients that could benefit from these services. Migraine patients, if they have vestibular manifestation, head impact, concussion, MTBI, patients with vestibulotoxicity, patients with medical comorbidities. Remember, the inner ear has some of the smallest, most sensitive vascular supply of the entire body. Patients with diabetes, peripheral arterial disease, atherosclerosis, arterial sclerosis, hypertensive patients, patients with connective tissue or rheumatic disorders, autoimmune problems, history of neurological conditions, falls, fall risk. All of these patients are potential candidates for testing. We cannot build a successful high volume balance clinic, seeing only patients that are surgical candidates that we think have dehiscence, for example. But when you integrate the tests the way that we do, and when you take a look at the battery that we're using, all of these patients are going to be potential candidates. So when marketing our services, when looking at who all could benefit, endocrinologists, cardiologists, rheumatologists, right? All of these different conditions, anytime that a patient has a complaint of imbalance, fall risk, dizziness, or vertigo, they could benefit from these tests. It's really important to remark on and to understand that vertigo does not have to be a presenting symptom in order for these patients to be tested. We are looking at equilibrium function. These neurodiagnostics evaluate the different modalities of equilibrium and how they are integrated and how the central nervous system is painting the picture of the world around us. So this is much, much bigger than just BPPV, vestibular neuritis, etc. All of these different patients and all of these different specialists could be referral sources here. So a lot of really, really exciting stuff when we look at who all may be a candidate for testing. To kind of highlight again why so many patients out there could benefit from this evaluation, equilibrium is a composite of vestibular, visual, and somatosensory information. These three senses feed the brain all of the information that it needs about the external world and help it keep us upright. So if a patient has a balance concern and we don't know how well is the vestibular system communicating with the brain, how well is the visual system, what about proprioceptives? Could it be a problem with the way the brain's putting the information together? Or is it a structural problem with how the brain is communicating with the feet, the ankles, the knees, etc.? So the neurodiagnostic protocol paints a picture and gives us this composite and helps us understand and recognize localization of the problem and a functional diagnosis. That functional diagnosis will then be able to be utilized by the physical therapist or the rehab provider in order to produce an outcome most efficiently. Again, I will go back to this is all about getting the patient better more quickly. So when we understand that equilibrium is not just this little organ that's sitting inside the head and the ear, it's much bigger than that. There are multiple processes in place, and we've got to do diagnostics that evaluate the totality or the entirety of this whole system. So once we understand these concepts, these very basic concepts of balance, we really start to expand our belief system and understand just who are good candidates and who needs these tests and how it's going to ultimately drive the outcomes. As we jokingly say, outcomes, outcomes, outcomes. That's what this is all about. Historically, one of the reasons that this testing has been somewhat discounted by the medical profession are a couple of different reasons. Number one, the testing was not utilitous for the practitioner. Back when when pretty much all we had to evaluate vestibular function was the VNG test, that test is somewhat antiquated. It doesn't tell us a whole lot. It doesn't help produce better outcomes. The other reason is it doesn't pay very much. When you just do a VNG, that CPT code pays about $100. This chart should kind of open our eyes to just what exists out there and what the available test battery is. So it's really nice. It gives you the diagnostic protocol, the sensitivity of that test, some of the pros, the cons, but ultimately, most importantly, how is it going to guide the vestibular rehab? That's what VRT strategies, the vestibular rehab, how is it going to guide that? And what are the post-rehab outcome measures that you can look at here? So again, we've got postural stability testing, the GANS SOP. We've got video head impulse test. We've got the VEMP test, vestibular evoked myogenic potentials, that now have a CPT code. So we get paid for that test now. That was started in 2021. Thanks to the VEMP codes, we have about a 20% increase in the total reimbursement of the vestibular codes from 2020 to 2021. So VEMP is a big deal, right? This is one of the only tests that looks at saccular function, inferior nerve function, and the lower brainstem descending pathways. We've got rotational testing, the rotary chair test, another wonderful test. The ROI on it takes 5 minutes, and actually the CPT pays about $117. Great post-VRT outcome measures as well. Also a great physiologic test. Dynamic visual acuity test. Finally, the VNG with caloric and the other evoked potentials, the ABR and the electrocochleography. So again, understanding that this test battery, the science of this, but also the reimbursement of this has grown considerably throughout the years. So by doing a comprehensive protocol now, we're able to generate in 90 minutes $595. So the ROI on these tests has improved considerably, and so has the science and the test, the ability of the tests to ultimately give us good information that's going to help get the patient better. So how much space do you need? The reality of it is this is another barrier for many clinicians or owners or practice managers, is there's this misconception that you need a huge footprint, thousands of feet, for example. But the reality is if you have one 10 by 10 room, 100 square feet can accommodate every single test that needs to be performed. So this is a big deal. It's very, very small footprint that you can do all of these tests in. And again, the reimbursement, about $595 per patient in this small of a room. So you don't need a large footprint. You don't need much space, right? All you've got to do is understand how to use the space that you do have efficiently. And taking a look at personnel and scheduling. In ENT and neurology practices, we recommend using a technician to complete the testing. These codes are able to be billed incident to, which allows the physician, as long as they are on premises, to supervise a technician to perform the tests. So rather than an audiologist, a highly compensated individual, rather than having them do this, we actually, in our clients and our centers, utilize technicians to perform the test. If they're trained appropriately by our team, we can do this and we can train them in 3 days, and they're able to perform these tests in a valid manner, but also an efficient, time-sensitive manner. So by opening up a technician's schedule, we're able to avoid having new patients have to wait. We're able to add capacity. We also enhance patient care and maximize the revenue without having mandatory physician participation. So in our model with our centers of specialty care, right, we have technicians perform the tests, we perform the overread for the physician, and by the time the physician is seeing the patient and implementing or recommending a plan of care, they have all of the information readily available to them. So we do not recommend having an audiologist do the test. That's not their highest and best use. They're able to dispense hearing aids. It allows them to manage or supervise the department, right, rather than having to actually do the technical of each test. So this is a huge, huge concept, this incident to billing, which allows your business to grow and your bottom line to continue to expand. So what is possible? These are a comparison of the 2020 numbers versus the 2021 numbers. So what we've got to understand about these charts is that these are based on a couple of assumptions. With the hearing tests, the audio codes, the audiologic codes, the total diagnostic revenue per patient is going to be about $681. Beyond the diagnostics, however, if we are receiving referrals from outside physicians or bringing patients in that have complaints of balance or dizziness, right? 30% of patients who are tested with balance problems or dizziness are going to have an identifiable sensory neural hearing loss, which could use hearing aids. 30% of that 30% of patients will move forward with technology if that technology is part of their overall plan of care. So if you're looking at our charts, our pro formas up here, we can look at this as a function of number of patients per month. So at 681 per patient, the test protocol, remember, can be done in 90 minutes. So a full-time technician should be able to perform 5 tests per day, which is 25 tests per week. That's 100 tests per month. So these are all quite conservative numbers. So if you look at what 60 patients per month is going to generate in diagnostic revenue annualized, $490,320. So very, very conservative, just over a half time, so just over 2.5 days a week, this technician can generate just shy of $500,000 annually. If we're looking at hearing aid annual revenue also because of our assumptions, right? $162,500 in hearing aid incremental increases. So our gross annual revenue from adding these services is only about is really realistically only utilizing a technician and should be $650,000 annually. If that number goes up to 80, you can see what things do as we increase number of patients that are seen per month. So the reality of it is this concept of there is no money to be made in balance. You can't make money with dizzy patients or vestibular folks. The tests don't tell us anything. It's really not beneficial. That truly could not be any further from the truth. So what this program allows you to do, right, if you treat this like an allergy or a sleep center, it allows you to add a significant revenue generating silo that does not require the physician's actual hands. So it's almost passive revenue. So understanding the concepts of this and how to make this business efficient and how ultimately you're going to improve quality of life for these patients and also add to your bottom line, that's what we hope you've taken away from our talk today. So these are just some of the exciting numbers. And of course, the increase from 2020 to 2021 is now that we have the VEMP codes. The other thing to understand about these codes, the assumption here, this is based on the Medicare maximum allowable of each of the CPT codes that we're billing. So this is all in the public domain on cms.gov, and you can go take a look at these numbers and how they may look. But this is based on Medicare rates. Thank you all very much for your time. It was a pleasure having you at our talk today. Hopefully you all are now interested in what adding vestibular diagnostics to your practice might look like. How do you help patients and improve your bottom line? So if you'd like to learn more about our Centers of Specialty Care programs, we'd be happy to chat with you and speak with you. Please visit dizzy.com or contact rgans@dizzy.com, and we'd love to speak with you about some of the exciting programs that we're now offering to see if your practice may be a candidate to work with us in partnerships. So thank you very much for your time. Really appreciate your attention, and have a great day.
Hi, this is Michelle Crone with Full Circle PR. We've been helping practices grow their patient base since 2007, and today I'm going to share how your front desk can make or break your practice. So what just happened in these 7 seconds? When it comes to first impressions, whether you want to admit it or not, quick judgments are made in this vital 7-second window. It's no different when it comes to the front desk of your practice. How your phones are answered and how patients are welcomed into your practice is the first impression they get before even meeting your providers. So first, I want to talk about defining your customer. And who is your customer of your practice? Well, we all know patients, but we also have to consider that vendors, other team members at referring offices, and the general public are all potential customers or patients of your practice. We're going to talk about professionalism, articulating your practice's message properly, and providing a high level of customer service in a fast-paced professional environment. So the importance of customer service. So there was a study published in the Journal of Medical Practice Management that reveals that 96% of patient complaints are related to customer service. Only 4% are about the quality of the clinical care or the health side of their diagnosis. So the study found that fewer than 1 in 20 online complaints cite diagnosis, treatments, and outcomes in healthcare, whereas 19 of the 20 unhappy patients said it's inadequate communications, disorganized operations that drove them to post the harsh reviews. Our study uncovered a torrent of patient allegations of doctors running behind schedule, excessive wait times to see provider, billing problems, indifferent staff, and doctors' bedside manners. Yet hardly anyone had a beef with the quality of healthcare received. And that is a quote. So let's talk the number one thing, phones. In over a decade that we have helped market these market positions, it still surprises us how many practices are simply not answering the phones, where it goes to a voicemail, when all any of us really want is to hear a voice. I know there's online scheduling, which is fantastic, and that is definitely an option. But for the patients that want to actually call, they want the phone answered. So think, how are your phones being answered? What does your phone tree look like? Is it super long and it has like every different option? And remember, if you have a phone tree, the number one thing should be for patients, especially new patients. Number two, then existing patients. Or vice versa. Number one, existing patients. Number two, new patients. Do your patients ever have to leave you a voicemail? If so, how fast is that message returned? So let's think about how we want to experience when we call a doctor's office for ourselves or schedule it for a family member. Do we want to go through this long phone tree, or would you actually like to hear a human voice? So phones 101, I want you to really think about how they are being answered. So again, we're going to talk about your phone tree. Keep your message short. Have a professional read a script that is provided that you've already reviewed, and then listen to that message from a patient's perspective. If you do have to have an on-hold message, which we would highly recommend, but it's a great opportunity to market. Let's say you have a new provider joining your practice. Here's a great time to say, oh, we would like to welcome to our practice, Dr. Jay Smith. His expertise is XYZ. Or did you know that October is Breast Cancer Awareness Month? Make sure that you schedule your annual mammogram. It's just a great way to market, and then change things often. Don't keep it stale, because a majority of your patients are usually the ones that are calling back and having to stay on hold. So keep it interesting. Do fun facts. That's also a great one to do. So the greeting. So when your phone is being answered, it says Dr. So-and-so's office or your practice name. This is, and let them state their name. How may I help you? Make sure there's a smile in their voice. Express readiness to assist the caller and address the caller by their last name throughout the entire call, if they get the last name. So, but it just sounds, and make it soft and slow and friendly. So closing the call. So it's also important not only how we answer the call, but how we end that call. Is there anything else I can help you with, Ms. Jones? May I set an appointment for you today? Our first available date and time. Thank you for calling XYZ practice today. Enthusiasm carried throughout the end of the call. And of course, patience. Obviously, there's a reason that our patients are calling the practice. So we need to have patience through the end of the call. And then your team member should really wait for that caller to hang up first. So there's definitely a direct correlation between physicians and staff. How your front desk conducts themselves has a direct correlation to the ability to keep patients returning to your practice. And those returning patients are often the ones that are bringing referrals. So for a position that's so critical to the practice's success, it is often overlooked and undertrained. But when it comes to the bottom line, it is well worth the investment to properly train your front desk staff. In addition, proper training also builds confidence in your team members. So undertrained front desk staff can spiral into unmotivated team members. The morale of the office goes down, which trickles down to how your patients are being treated. An unhappy patient eliminates loyalty to the practice. And then before you know it, the practice is struggling to get patients back in the door. The average front desk person's salary or hourly wage is like $15 an hour. So investing in employees also means investing in their training. Too often someone has put the front desk to answer the phones and greet patients, but they're never given any training on how to conduct themselves and what to say. As stated earlier, the person answering the phone is often the lowest paid position in the practice. So for the first line of public relations for your practice, you want to consider the old saying, you get what you pay for. Focus on hiring someone who is friendly, has great communication skills, is a patient listener, and when you find this person, pay them well. It is well worth it. So let's talk about the test. And this is going to be really for all, not just your front desk. Of course, we are focused on the front desk, but also all of your team members. And this is a little bit of homework. You can pause this now, do it now, or do this after. But I really want you to think about your team members that interact with your patients. Rate them on a smile level throughout the day on a scale of 1 to 10. And let's keep going with this. Okay, so with this, think about how they interact with patients. Are they very disconnected? They are really just trying to get through the day, get home. They don't really care about the patient. They're just there for money. Or do you have team members within your practice that really make that patient feel important? No matter if that patient is a happy-go-lucky patient or it's one of your very pessimistic patients, but you have people within the practice that can show empathy and just a simple smile. I mean, these patients are coming to you normally for good things, but how we're being treated as a patient really goes a long way too, even when it gets to the physician, because it makes that physician's job a little easier to have not to deal with an unhappy patient. So we want to make sure on our end for the team members of the practice that we can smile and show warmth. So I want you to do this as part of your homework and think about your team members and rate them on a scale of 1 to 10. 10 is a little much. It's okay. Some patients, great. But we kind of want that middle to high zone. So smiling. It is honestly the easiest and most attainable requirement, especially for your front desk staff. Tone of voice conveys 84% of the conversation to the patient. So really, smiling immediately puts people at ease and makes them feel that they're important, which they are. So train, train, train. I can't say this enough. Once you have found those great team members, now it's time to train them well. Do they know what insurances you take? Do they know about all the services you offer? Your staff needs that one-on-one guidance to make sure that the office is successful. Scripting and role-playing is a tool that can help. How many of you have team meetings, whether it's weekly or monthly? That is a fantastic opportunity to lead with a question, or what was the most challenging patient that we faced this week? And how did we handle that patient? How can we do things better? But during these team meetings, it's a fantastic opportunity to really work and train your team. So 62% said that a representative's knowledge or resourcefulness was a key to their positive experience. So on top of that, 26% of the callers get annoyed by a representative who has no knowledge or no ability to solve their issues. So think about that too. What can you empower your front desk to know so it's a great experience for that patient or a potential patient that's calling you? Professionalism. So we've all experienced going to especially practices that there is zero professionalism. It is team members chatting at the front desk about what they did over the weekend, laying on the front desk, answering the phones, you name it. I think we've probably heard or seen it all. But think about what activity is going on behind that front desk. And you have to, again, reiterate team meetings, great time, reiterate to your team members that they have to keep their personal lives and things behind closed doors. That's what the lunchroom is for. So behind the front desk is all about professionalism and the patient being number one. Communication. So with this communication, let's talk about your check-in process, including the paperwork. Come through mentally, go through your front door. And I'm going to talk about the aesthetics of the office in a second, but come through your front door. What is your check-in process like? Is it something that makes you feel warm and fuzzy that you want to come to your practice? Or is it something that just feels very cold and stale and you're just not getting a good vibe? So think of it from a patient perspective. Look at that paperwork. Paper crooked, if you're still doing paper, if you have tablets, probably not the best time to have tablets. Maybe look into contactless check-ins, something like that to show, you are up technology. Inform patients on how long they'll be waiting. So put yourselves again in the patient's shoes, or let's just say we're at an airport and all of a sudden your flight's delayed. And you have no clue whether your flight is delayed 10 minutes or it is delayed 8 hours. But as soon as someone comes up and lets you know how long it's going to be, you now know what to expect. So it's all about communication. Inform the patients how long they're going to be waiting. So a natural reaction, of course, is to avoid confrontation. But this is where, again, role playing with your team members, especially at the front desk, can really come into play. And have it where if your doctor is one of those physicians that just run late, and we all know how those are, but how do we communicate that to the patient? Maybe we offer them a smile, small talk, a bottle of water, and then let them know about how long they're going to wait. If it's longer than X number of time, and it's determined by each different practice, but maybe offer them to reschedule or go grab lunch and come back as we're running about an hour and a half behind. But making sure the patient feels that they are being communicated to. And of course, ensure the patient doesn't feel like a nuisance. And I know that we've all experienced this as well when you walk into a place, whether it's a hostess at a restaurant or the check-in person at the airport, or even another physician practice, where you feel like it's a nuisance to be there. So make sure that whoever is at your front desk does not make your patients feel like a nuisance. So how does your practice look? Again, we're walking through the front door. What does your waiting room look like? What do your exam rooms look like? Again, this is going back to kind of, usually the front desk is the one in charge of making sure, especially the waiting room, but even the exam rooms, on what do they look like? Are they completely disheveled? Do you have papers being hung up and they're curled at the ends with a piece of tape? Think about how that looks. You want your office to portray an image of professionalism. Again, a piece of homework to do. So your practice's message. What do you want your patients to say about your practice to their family and their friends? Do you know the values of your practice? Do you have them? Do your team members share them? Do they even know them? Again, I keep going back to these team meetings, but it really is so important. So that way your practice, your team members know what you want the message of your practice to be and what the values are for your practice. So signage, it's a great thing to add to your lobby. It's a great thing if you have room in the exam rooms. It's fantastic. If not, the lobby is great. Again, talk about the values during these team meetings and reward your team members that actually put your values into play. So it's amazing what even a little Starbucks gift card will do for a team member. It's just about recognition. So when you see a team member actually using your values and putting them into play, reward them. Show the rest of them, of the team members, that, hey, we really value when our values are being implemented. So think about that as well with your practice. It'll go a long way. So customer service. We talked about acknowledging your patients. We want to describe kind of what your patients are going to experience and everything from, and this is what I'm talking about with telling them about the time. So you'll be sitting here, we're running about 30 minutes behind, and then we will have Sally come and get you, and she's going to take all your vitals, and then you'll be in the exam room and the physician will be in as soon as possible to see you, describing what they will experience so that way they know and have more of a comfortable feeling. Respect patients' time. That is the number one key. We all just want to be respected with our time. Everyone's busy. So if they're coming, if you're running more than 15 minutes late, let your patients know at check-in. Then if it starts getting way beyond that, for patients that, like, let's say, I mean, there are the days that I know physicians are running 2 hours behind. Call the patients that are on the schedule and give them the option of rescheduling, because that is crazy to be waiting in the waiting room for 2 hours. And then finish strong. Let the patient know that you appreciate them. Thank you for coming in today. Let them, just give them that warm, strong, of course, it depends on why they were in. So I'm going to leave it up to each practice. Again, during your team meetings, role playing, what's a great way to just let the patients know that you appreciate them and thank them for entrusting your practice with their care. So these are just a few phrases that I just want to go over, frightening phrases. I don't know, we can't do that. Oh, big one. No, you'll have to, just a second. Versus 5 soothing phrases. That is a good question. Let me find out for you, Mrs. Smith. Here's what we can do for you, Mr. Jones. Offer a positive solution, and then you will need to call 555-123-45678 to make your imaging appointment. Are you able to hold? This may take a moment. So these are just a few phrases that I came across during my research that I thought was really good to just share with you all. So did you know a dissatisfied, well, we're talking customer, but we're going to say patient here, is going to tell between 9 to 15 people about their experience. 13% of dissatisfied customers tell more than 20 people. And now that we love sharing things on everything social media, we really put it out there to probably even more than that, because this is research back from 2019. But happy customers who get their issue resolved tell about 4 to 6 people about their experience. And it takes 12 positive experiences to make up for 1 unresolved negative experience. So we all know that we are really fighting for these great Google reviews. So between Google and Facebook and now even Nextdoor, we really need to focus on making our patients feel so welcome and like that they are customers. In a way, they are. So let's talk about the reviews. So we all know when we are doing reviews, even if we have to find the physician practice, most of us go to Google. 94% do a search on Google, and you put in the name, and of course, what's the first thing that comes up with the map? The reviews. So if you have 2 stars and like 5 reviews, that's not good. We need to really look at your reviews and getting them up. So ask happy patients to review. There's so many different options as far as software now to help. And then responses. You have to respond to these reviews, whether they're positive or negative. The positive reviews are like, thank you for the 5 stars. And the negative reviews cannot say anything about them being a patient or imply in any way they were a patient. But you want to say about how customer service is one of your core values, and please call, and usually we put an administrator's phone number, as when you can, so we can talk more. And that's a great way to kind of negate those negative reviews and have them call the practice. So all patients want is to be treated with respect, to have their problems solved, immediate action, and more proof that you were listening. I want to thank you for your time. And just remember, we really want these patients to feel that they are important. Thank you again.